Yeah, so welcome to Decoding CTO, case 42. I'm Dr Sharath Reddy, intervention cardiologist, Medicover Hospitals, Hyderabad. So in this session, I'm discussing a case of reverse wire technique to enter side branch in a CTO PCI. My patient is 64-year-old male, chronic stable angina with good LVRV function. Had LED CTO in angiogram. So this is coronary angiogram, which showed can see total occlusion of mid LED, yeah, this is a total occlusion of mid LED, and you can make out there are a couple of branches coming out of at the proximal cap of CTO, and cap is completely ambiguous. So this is RCA injection showing distal flow into the LED, and it looks like around 20 millimeters of length, but clearly proximal cap is ambiguous. And you can also notice a branch at the distal cap. You can see there is a bifurcation even at the distal cap. There's a big diagonal sitting at the distal cap. So this is during coronary angiogram, just to assess the length of CTO. So you can take in the same view, you just take retrograde injection just to understand. It looks like maybe around 20 millimeters of CTO, or it could be slightly less. Yeah. So JCTO score, basically it's an ambiguous cap, and length maybe around 20 millimeters. So hardly score is 2. But the challenges here are, the first thing is ambiguous cap. So we have to use, because there is a good side branch here, so we can use this side branch for IVUS guided cap puncture. So this is a septal, it's too small, so it's not fit for doing IVUS, the Boston Opticross IVUS, which I use. But this branch can be used. You have a good length of branch. But out of these two branches, so from which branch you have to do, I think I prefer this branch because it is closer to the the vessel which we have to image. So we prefer this branch for IVUS guided cap puncture. And then once if you reach distal true lumen, so the next important challenge is how is your diagonal. So since the diagonal is originating very angle is too bad here, so and it's almost like a cranial angle, so the possibility of compromising diagonal was quite high. So just pre-dilate with a small balloon, and then try and interrogate with IVUS, and then wide this diagonal. Then only we go with the full dilatation of CTO. So that was the plan. And if it doesn't, if you couldn't wire, then we can use a reverse loop wire technique. And also, if the wire is not going into true lumen, so then obviously we end up in doing a retrograde intervention. So if we go retrograde, the possibility of saving even the diagonal branch is much more better than simple antegrade. So that's a plan. So we went ahead with dual injection, and you can see in dual injection clearly this is the branch through which I wanted to do IVUS, and this is the distal bifurcation. So what's happening here is the branch is actually overlapping and appearing like a connection between proximal and distal vessel, so which is not true. This is the CTO segment. This is IVUS in the branch close to the proximal cap, and then you can see, yeah, while we're coming out, you can see this is the vessel which is coming and joining. It comes closer now. This is diagonal, and it joining diagonal. It's almost at the site of confluence. This is confluence site, and now you can see the big change in size of the vessel. So that says that is the entry point. So yeah, you can also see here in running IVUS, this is the vessel which came and joined, and now the size is increased. So that is the proximal cap which we were supposed to enter. So yeah, under IVUS we wired CTO, and then we are checking the wire position. You can see this is the wire, so this is the proximal cap. So it appeared it's in good position. So then we further advanced wire. You can see now the Gaia is actually subintimal here. We went across CTO, and now it is subintimal here. You can also see in two orthogonal views the wire is looking subintimal. And if you enter like this here, so obviously you end up in losing the diagonal. So the point here is, so either we have to redirect the wire towards distal cap, or you just go retrograde. So yeah, so what we did redirect Gaia 2 wire. Now you can see it is exactly Gaia 2 wire is sitting on the distal cap, unlike the past position which was actually quite medial to the distal cap. So it's right on the top of the distal cap. So now we entered and confirmed in two orthogonal views. So you can see here the wire is in LED, and in allocranial also wire is looking in LED. But what is not clear for us is how the diagonal ostium behaves. So was there any flap here which can occlude diagonal ostium? So that is something which is very important. The next immediate step is saving this diagonal. So as planned, we did 1.25 mm balloon dilatation followed by IVUS. You can see in IVUS, you can see this is diagonal. Yeah, you can see this is diagonal, and you can see this is the flap on the ostium of the diagonal. So I'll play here. Yeah, you can see this is the flap. This is the diagonal ostium, and this is the diagonal ostium, and this is the flap. So there is clearly a flap on the diagonal ostium, so which is causing the obstruction. We tried wiring it, but we couldn't wire in a regular way. You can clearly see. So there is a flap on the diagonal ostium at 4 o'clock. Okay. So once we notice this finding, so I'll also show you in frames, steady frames. You can see here. So this is a diagonal ostium. This is a diagonal ostium, and you can see this is the flap. So in front of the diagonal ostium, and you can see this is again the flap, diagonal ostium, and there it joined, but yeah. So and now the size of the vessel is clearly increased. So clearly there is a flap, so that prevents wiring up that side branch. So that's when we had to take a reverse wire technique, which we predicted even before. So this is how we can do a reverse wire technique. So take a bend, this is the primary curve, and take another curve here. So and this curve, it should be like 20 mm proximal, to the primary curve. So, and you have to introduce through the double lumen catheter. So you introduce double lumen catheter along with this portion into the Y connector, and it has to be pushed without holding the wire. And the wires which are conducive for reverse wire technique are either filter FC or pilot 50, or sand block also can be used. And you can see how to push it. See, this is how you have to push it. So your wire should move along with crusade catheter. And you can see this is how we have sent the wire inside along with the double lumen catheter. This is a double lumen catheter, and take the wire tip just below the target branch. Never take it too much down, so because it keeps entering into multiple branches, and we have to understand the torqueability of reverse wire is, it's not much torqueable, so you have to just target it and push the wire, that's all. I mean, when you pull the wire, it automatically goes into it. So yeah, first we went into a distal diagonal D2, but later we just pulled it back. Now you can see it entered our target diagonal. So once it entered, so we have to just pull it back, and obviously the wire goes deeper into the side branch. So this is where, I mean, a little bit of knuckle formed in the wire. So, but we just advanced the wire with the knuckle down. So, and yeah, you can see now the wire is moving down, and it just went into diagonal. Yeah, in fact, we created a little bit of dissection here, which I will show you in the IVUS, which is okay. So we did IVUS from LID to understand the diagonal wire position. You can see this is a diagonal wire and almost disappeared and reappeared here. So I'll show you in static images. So you can see this is the diagonal wire and the diagonal wire, and this is all the flap which I set, and the diagonal wire, and this is all the flap which is basically indented by your wire. And I can see this is again the flap, and a little bit of block as well. And you can see here almost the wire is not visible because of the block and flap combined. So, and now you can see the wire again. So obviously it's a retro entry, so that is the reason we are not able to see it at one place. So we took a valve ring, cutting balloon. So we did a cutting balloon at the ostium of this diagonal. So this is important mainly to split the flap, so that we can do only provisional side branch stunting technique. So but adequate splitting of flap is important, otherwise flap can close diagonal. So sometimes we can even use double kissing cutting balloon. So put a cutting balloon in LID as well as diagonal, and do a kissing balloon with cutting balloon, so that you can create good fenestrations in the flap which won't occlude diagonal subsequently. So we can see IVUS again after post cutting balloon. Yeah, as I already mentioned, because of the wire knuckle, there was little subintimal course here, but again at the ostium the course is clear. Here it's all in true lumen. So this is the ostium. Now you can see the flap is completely split, and yeah, there is high possibility that we may not lose this diagonal. So then we stunted with the 328 mm stunt across the diagonal. You can see there is a tight stenosis of diagonal, but flow is there, so it's not completely occluded. And if it is a flap occlusion, you don't see diagonal at all. So there is only 99, maybe 95% lesion. So we did a kissing subsequently, And now you can see, diagonal is flowing nicely. And yeah, but there was a small dissection here, but it's okay. That's not an issue, so that will heal. So this is the final result. To conclude from this case, side branch at distal cap of CTO poses challenges in PCI. Sometimes you can even see side branches within CTO. After antegrade wiring, preferably dilate with 1.5 mm balloon for only IVUS interrogation of side branch origin. Any flop or plaque over side branch makes entry difficult. That has to be clearly observed. And reverse wire loop with WMN catheter would help in wiring such side branches. And cutting balloon of side branch or kissing cutting balloon can split the plaque flap combine, and it facilitates only provisional stunt strategy. So thank you. So for such videos, you can subscribe to our website or our YouTube channel, which is interventionalstrategies.com, right?
Yes.
Yeah, interventionalstrategies.com. Thank you.